Thank you for joining us. My name is Jenny Pagel-Guile, and I am the Executive Director of the National Pancreas Foundation. Our mission is to provide hope for all of those suffering from pancreas disease through funding cutting-edge research, providing support and education, and advocating for better services and access to care. Some of the impact of the National Pancreas Foundation is awarding over 5 million grants to up-and-coming researchers to keep them in the pancreas field and moving care and treatment forward. We've endorsed over 180 centers of excellence across the country, from cancer, pancreatitis, and pediatric, recognizing that there are needs for all of our patients and, again, elevating the highest level of care. We also provide a variety of programs to volunteers, care providers, and medical professionals as well. There are many ways that you can be involved in the Pancreas Foundation, as well as several resources available online and on demand. We have the animated patient that provides detailed information about the diagnosis as well as the pancreas itself. We co-sponsor Camp Hope with Rebecca's Wish, our first pediatric pancreatitis camp in the country, and we provide nutrition support through our cookbook services and online webinars. All of this information can be found on our website, as well as a listing of all of our active centers of excellence. Across the country, we have over 30 chapters. These are volunteers and individuals who provide support to each other. They also provide grassroots efforts at tabling at local health fairs, providing fundraising support and education. They also sit in on advocacy calls at the local and national level. We would love to have you join us if you are able, or you can start a chapter in your community. Reach out to our staff if you would like to receive more information. Again, we have a full calendar of events, virtual and in person, on our website. We have an assortment of galas across the country. We have patient education events coming up in person, as well as medical professional events. And again, all of our webinars are available on demand online. The best way to stay up to date is to subscribe to our monthly newsletter. We also are on a variety of social media, so make sure that you follow us and share with your community and peers. We would love to have you join us. I have the pleasure of introducing our speaker, Dr. Andrew Coveler. He is an associate professor in the Division of Hematology and Oncology at the University of Washington School of Medicine and in the Clinical Research Division at Fred Hutchinson Center for Cancer in Seattle, Washington. He is a GI oncologist with an interest in early phase clinical trials and novel agents, especially ADCs and immunotherapy. He is the medical director of the Pancreas Cancer Specialty Clinic at the Fred Hutch. Dr. Coveler received his medical degree from Northwestern University Feinberg School of Medicine in Chicago, Illinois, and he completed his internship at Baylor College of Medicine in Houston, Texas, his internal medicine residency at the University of Washington, and his hematology oncology fellowship was at the Fred Hutch Center for Cancer. Thank you for joining us.
Hello, I'm Andrew Coveler from the University of Washington and the Fred Hutch Cancer Center. Today I'm going to speak about the treatment and evaluation of patients with borderline and high-risk resectable pancreatic cancer. My outline for the day is that I'm going to talk about pancreas cancer treatment overall in one slide. I'm going to go over how to stage pancreas cancer and what we're looking for in the defining of borderline high-risk resectable disease. I'll then go into the treatment of that, mostly from a medical oncologist standpoint, and then a brief summary. So this is how I think of treating pancreas cancer in one PowerPoint slide. I start from the bottom and move my way up. And the first thing I like to point out is supportive care treatment that is due for all patients, which is that pancreatic enzymes should be evaluated if they need that, such as early satiety or diarrhea, bloating, and all those symptoms. And likely patients with pancreas cancer should sometimes see a registered dietitian for evaluation. Weight loss is quite common and eating is difficult, especially with chemotherapy. Pain management should be optimized as much as possible. Stents are needed, usually for biliary decompression with pancreas cancer. Palliative care with or without spiritual health should be something to consider given the multiple symptoms that come with the disease. And germline genetic testing is recommended for all patients with pancreas cancer. As we move our way up, you come to metastatic disease, which is not the focus of this talk, but it's a good place to mention what are really the main chemotherapy regimens that we use throughout the treatment of pancreas cancer, which would be FOLFIRINOX or now Arifox, a regimen of folinic acid, 5-FU or 4-uracil, irinotecan, oxaliplatinum. Obviously, in now Arifox, the irinotecan is changed to liposomal irinotecan. Gemcitabine nab-paclitaxel is the main other competing regimen, I guess I would say. And now Leary is for people who have received gemcitabine nab-paclitaxel in the first line setting. Many places will use FOLFIRINOX or gem nab-paclitaxel in either the first or second line. For locally advanced disease, the treatment is usually chemotherapy, subsequently with or without radiation, with or without treating tumor fields, and with or without surgery as able. The chemotherapy regimens, once again, are the same for the metastatic disease. For borderline resectable, the main difference between that and locally advanced, which is we'll get to in more detail, is that you're expecting to go to surgery if your cancer doesn't get worse. So it's chemotherapy plus or minus radiation prior to surgery, often followed by more chemotherapy, but maybe not, with or without radiation if it wasn't done before. And then resectable disease, though there are places where it's being treated also with neoadjuvant or perioperative therapy. Technically, I think if you went to a test question, it's in theory surgery first, followed by adjuvant chemotherapy. Also, in the setting of many of the vaccine trials that are going on in the adjuvant setting, it's surgery followed by adjuvant chemotherapy with the vaccine and immunotherapy built in there. So going to move to focusing now on borderline and high-risk resectable disease, which I may interchangeably just call it borderline disease, but overall these two settings are treated the same. So first I want to take a moment for what is adequate pancreatic cancer staging, mostly taken from NCCN guidelines. But obviously, staging evaluation starts with the history and physical, and a good functional evaluation, which is more than just the ECOG performance status, but functional evaluation is important that you think they're going to tolerate the neoadjuvant chemotherapy if indicated, and the subsequent surgery. Laboratory evaluation is mostly and usually a complete blood count, a comprehensive metabolic panel, especially including the liver function tests and the bilirubin. Tumor markers of CEA and CA19-9 are useful, and we'll talk about that more as we talk about high-risk disease. And then, importantly, CT scan of the chest, abdomen, and pelvis, and more specifically, a pancreas protocol CT. So importantly, these things are ideally done within 4 weeks of, I'm going to say, whatever it is you do to someone with pancreas cancer. If it's surgery, if it's neoadjuvant therapy, pancreas cancer can change quickly, and having adequate and appropriate staging for assessment of resectability is important. And then just to make sure you're not dealing with imaging that's old, so you know what your treatment does. Ideally, imaging, such as a pancreas protocol CT, will be done before a stent is placed if needed. Just because that decreases the risk of having a stent artifact and potentially inflammation. I am not going to read you all the notes there on the right side, but some main things I wanted to point out is that a dedicated pancreatic CT of the abdomen is preferred. So once again, a pancreas protocol. Ideally on a multi-detector CT scan that's going to perform by acquiring thin, preferably sub-millimeter axial sections, dual phase with a pancreatic and portal venous phase. These things all really are needed to provide the best staging information. Multiplanar reconstruction is beneficial, so you can get better evaluation of the tumor and the mesenteric vasculature. And then MRI is usually used as a problem-solving tool to help characterize, for example, indeterminate CT lesions, or if the pancreatic tumor is not visible on the CT. Of course, it's an appropriate imaging modality if there's reasons you can't give someone iodinated contrast. So moving on to what is borderline high-risk resectable disease? first focusing on what borderline resectable disease is. So borderline resectable disease, in my head, I generally think of as what resectable is and what locally advanced is, and then borderline's in between the two. So what's resectable disease? I usually think of it as no arterial contact. That can be the celiac artery, superior mesenteric artery, the common hepatic artery. In simple terms, I think of it as it's not contacting the veins, being the superior mesenteric vein or the portal vein. Technically, if it contacts those with a less than 180 degrees and there is not contour irregularity, it's still resectable. And if you're a pancreas cancer expert, that's probably going to be in your area to think about. But if this isn't something you see all the time, I usually, once again, just think of it as not having any venous contact. Because the truth is once there's any contact, I'm pretty much talking to a surgeon to figure out what they want to classify it as. So locally advanced patients, jumping to this area, have arterial contact on the SMA or celiac artery greater than 180 degrees. The SMV or portal vein is not resectable or reconstructible. And for body and tail lesions, there's contact with the celiac artery and the aorta. So let's take a look at these pictures. These are patients who have borderline resectable disease. And here you can see the tumor causing contour irregularity here on the portal vein with less than 180 degrees contact. And here you can see it abutting the SMA, once again, less than 180 degrees. Here's from the NCCN guidelines, the same information in more detail. Roughly the highlight information I put on the previous slide, and is what I mostly try and think of to define this. And then you have the borderline resectable category that is more well developed in this area. So I, for example, didn't have on the last slide that solid tumor contact with the inferior vena cava would make it also borderline. So once again, my simple thought is if it's not touching the arteries and the veins, it's resectable. If it's wrapped around the arteries, it's locally advanced. And pretty much anything in between, I discuss. Well, I discuss most of my patients at the multidisciplinary clinic, but that's how I can think of it in my head simply. So there's the borderline resectable patients. Let's talk about high-risk resectable. What is high-risk resectable disease? The NCCN guideline starts off by saying it's equivocal or indeterminate imaging findings. And though you can't always resolve those, I really try hard to make things not equivocal or indeterminate. That might be MRIs, might be biopsies, might be a surgical, procedure to look at something. Knowing what you have up front, I think is important, though not always, of course, doable. Markedly elevated CA19-9, and that's a common one. So I tried to look for a definition, and when I initially started this talk, I thought there's going to be a clear definition of what high-risk resectable disease is based off of the tumor marker, and it's not. I've had studies that went as low as 130, and seemingly around 400 is where most studies looked at on the upper limits. But there were studies at all of these different time points that show figures relatively like this. So looking at figures D, E, and F in this picture, these are pre-resection CA19-9s, and this one has a normal bilirubin. This one had a corrected CA19-9, which was just the CA19-9 value divided by the bilirubin if it was greater than 2. And then there was also about perioperative changes of the CA19-9. And what you can see is that if there is some level where you can break it, that if your CA19-9 is higher versus lower, that the patient who is higher does worse, whether it's corrected or not corrected. So as we all know, CA19-9 can go up with biliary dilation and obstruction. So that's where that calculation comes into trying to normalize it a bit. And then if it is elevated, what you can see is getting to normal is better than, is the best. Having any decrease seems to be somewhat better than, of course, if it gets worse or if the CA19-9 goes up. So I'm not going to really be able to answer to you where the level is that you definitely want to say it's elevated and it's high risk resectable. 400 seems an upper limit. 200, I think you're going to start looking at other things to try and put it all into picture. But as you'll see on my next slide with references, you can choose many different areas. So large primary tumors, once again, not well defined. Is it 3 centimeters? Is it 4 centimeters? I don't know. Large regional lymph nodes, you know that they're technically resectable. You're still in the high risk or borderline resectable status. But generally, I get concerned if you can see and tell lymph nodes are abnormal on CAT scans. I just noted that N2 disease does now equal stage 3 disease, and that's just for prognostic information. Excessive weight loss might indicate worse disease than we're seeing and is something that could be considered a high risk thing. And pain, that's concerning. I think the guidelines called it extreme pain, but then you're worried really, I think, about celiac plexus invasion or something being underrepresented on the CT scan. These are references for some of those various CA19-9 levels. So now that we've established what borderline resectable is and what high-risk resectable disease is, let's talk about what the treatment options are. Once again, in summary, I think of it as chemotherapy before, with or without some radiation before surgery. Once again, if someone doesn't get worse, these patients should eventually move to surgery. And then after surgery, there may be more chemotherapy or radiation if it wasn't given in the neoadjuvant setting. Usually radiation is only given one of the two times. Some people push for total neoadjuvant therapy. Some studies have been looking at perioperative therapy. And there are many phase 2 studies, there are many smaller studies, and there's really going to be no definitive answer in the end for this. So, just to reiterate the point, there's no agreed upon standard for borderline resectable pancreatic cancer patients or treats locally advanced patients regarding the benefits of chemotherapy or radiation alone or in combination. So instead of showing you many small phase 2 or specific studies, I did focus a little bit on meta-analysis. Here, we're looking at the benefits of neoadjuvant therapy in a systematic review of randomized trials, comparing neoadjuvant therapy with upfront surgery for resectable and borderline resectable pancreatic cancer. The primary outcome was overall survival by intention to treat. There were 7 trials with 938 patients. This was published in 2022, and all trials included a neoadjuvant gemcitabine-based chemoradiotherapy arm. None of the studies used adjuvant FOLFIRINOX here. Looking at the data, what you can see is that neoadjuvant therapy improved overall survival. That's probably best seen right here in the forest plot. The hazard ratio is 0.66, which would calculate to a median overall survival improvement of 19 to 29 months. In subgroup analysis, in the resectable patients, there was no statistically significant difference in overall survival, though it trended that way. It did cross 1. And in the borderline resectable patients, you can see that it was a greater result and did indeed stay on one side. And neoadjuvant therapy seemed to improve overall survival. So the conclusion was that neoadjuvant therapy improved overall survival compared with upfront surgery in patients with borderline resectable pancreatic cancer patients, and more evidence is required on whether neoadjuvant therapy improves survival in patients with resectable disease. So once again, the regimens are FOLFIRINOX and Gem/Nab-Paclitaxel. I will also show some slides from ASCO 2025 regarding a regimen called PAX-G. So gemcitabine nab-paclitaxel versus FOLFIRINOX. There have not been many head-to-head trials. There's been a lot of retrospective data. But as an example, here's the SWOG 1505 data that was done in resectable patients, trying to figure out if one regimen was better than the other one. This randomized phase 2 trial did not demonstrate improved overall survival with perioperative chemotherapy compared to historical data. And the 2-year overall survival, interestingly enough, for these two regimens was the same, or essentially the same. When you looked at outcomes in patients undergoing surgical resection, though the p-values here are all not different, it looks like there's a slight trend in truth towards a better pathologic response with Gem/Nab-Paclitaxel. Looking at a single institution retrospective study, they found the mean overall survival for FOLFIRINOX was better than Gem/Nab-Paclitaxel for 38.7 versus 28.6 months. You can see that the confidence intervals, though, do seem to overlap. After adjusting for age, resectability status, tumor markers, etc., it wasn't a statistically significant benefit, but FOLFIRINOX still seemed to increase overall survival by about 4.9 months. And in a bigger study, an international multi-center retrospective study at 16 centers, about 1,000 patients, most people were receiving FOLFIRINOX at a 2-to-1 ratio. And FOLFIRINOX was not associated, once again, with a statistically significant benefit compared to Gem/Nab-Paclitaxel, though the hazard ratio did numerically seem to favor FOLFIRINOX. So let's look at something that was presented this year at ASCO 2025, which was PAX-G versus modified FOLFIRINOX. This was designed as a phase 2 study to demonstrate superiority of PAX-G over modified FOLFIRINOX for subsequent phase 3 testing against standard of care therapy in resectable and borderline patients. This is based off of the fact that PREOPANC-1 demonstrated superiority of neoadjuvant gemcitabine-based chemoradiation over upfront surgery. PREOPANC-2 demonstrated no difference between neoadjuvant gemcitabine-based chemoradiation and modified FOLFIRINOX. As modified FOLFIRINOX became a standard option, the trial was changed to a phase 3 trial. So patients had stage 1 to 3 disease. They were resectable or borderline resectable, had decent performance status, were between 18 and 75, and were untreated. The treatment of PAX-G is cisplatin, nab-paclitaxel, and gemcitabine every other week, and the capecitabine is continuously given at 1250 milligrams per meter squared in a day. It can be divided. If there was no progression, people continued on study and were randomized again to either surgery or 2 more months of chemotherapy. So hopefully this study will answer the question of whether total neoadjuvant therapy or perioperative therapy is better for patients. The primary endpoint was event-free survival. This included progression by RECIST 1.1, recurrence, unresectability, intraoperative metastatic disease, CA19-9 failure, and death. Secondary endpoints were response rate, CA19-9 response, resectability, past CR, toxicity, quality of life, and overall survival. The event-free survival is the primary endpoint, and you can see that at median follow-ups that were about equivalent. The event-free survival was better in PAX-G. The 1-year event-free survival was better at 60 versus 45%. And the 3-year event-free survival was 30 versus 13%. The hazard ratio was 0.64, and some of this was due to CA19-9s, but you can see that death was very similar. The intraoperative metastatic disease was only slightly better. Recurrence looked a little bit similar, though there was seemingly also more progression. a little bit. Of who benefited at the 3-year mark, what you can see is that pretty much everyone benefited from PAX-G over FOLFIRINOX, except for maybe the KPS group that was less than 90, but that was only 8 people. Separating resectable and borderline resectable patients, we can see 2 things. One, event-free survival was still improved by almost doubling in both groups. But that borderline resectable patients aren't really just resectable patients with slightly worse disease. They do clinically significantly different, as one can see by these numbers. The overall survival data is currently immature, but is trending towards PAX-G being better than modified FOLFIRINOX at median, 2 years, and 3 years. I'll point out that if you look at 3-year overall and disease-free survivals, it does seem that every drug we add to an adjuvant regimen adds about another 10%. If you think of gemcitabine to gemcitabine capecitabine to FOLFIRINOX to PAX-G. Subsequent therapy was given to these patients, and this is shown here of what kind. Secondary endpoints were overall improved with PAX-G, which include disease control rate, CA19-9 response, pathologic complete response, which was still very low, but 3% versus 0, number of patients without lymph node involvement, and then finding metastatic disease at surgery was also much lower with PAX-G versus modified FOLFIRINOX. The resection rate, though looking slightly better, was about the same, and the RECIST best response was also similar. So looking at selected adverse events, these 2 regimens, I would say are overall similar. There is slightly more neutropenia, and obviously with capecitabine, there's some hand-foot syndrome that you usually don't see with modified FOLFIRINOX, or not at least as such a significant grade. So what is the role of radiation therapy? And I'm not a radiation oncologist, so I'm going to show one meta-analysis. There's obviously more data to look at than what I'm showing here. There's both IMRT and SBRT and short and long course options. So this study did a systematic literature search with a primary endpoint of overall survival, with secondary endpoints of disease-free resection rates and R0 resection rates. There were 31 studies. 14 had neoadjuvant chemo alone, and 19 had neoadjuvant chemotherapy and chemoradiation. You'll see that the neoadjuvant chemotherapy had a higher median overall survivals than the chemoradiation. You'll see that the R0 resection rate was better for that with chemoradiation, and there was no significant difference observed in disease-free. Interestingly, what was seen is that in patients who received 5 or more cycles of initial chemotherapy, chemoradiation was then associated with longer overall survival than neoadjuvant chemotherapy alone. So it does seem to support what I feel most places are doing, which is giving chemotherapy first before chemoradiation if they're going to use that. And then chemoradiation does seem to improve the R0 resection rate, and then that may translate to a small improvement in survival. So I think I've summarized the chemotherapy and radiation paradigm before surgery, maybe with postoperative therapy. So whether it's total neoadjuvant therapy or perioperative therapy, I would say is unknown at this time. And this is, again, just the one slide summarizing all treatment of pancreas cancer as best as I can condense it. Thank you for your time and your attention.